Shall we start, sir?
I don't see a slide. Okay.
Sir, general club presentation. I'll be presenting indication and timing of pulmonary valve replacement after tetralogy of Fallot, studied by Tal Geva, who is the chief cardiac surgeon at Harvard School, who has worked extensively in TOF and pulmonary valve replacement. Sir. The article from 2006. Sir. The introduction. Sir. Tetralogy of Fallot, the most common type of cyanotic congenital heart disease with an incidence of 356 per million live births. From the time of Lilly's TOF repair under cross circulation in 1954, the surgical management of Tetralogy of Fallot has evolved to primary repair. Severe chronic pulmonary regurgitation, considered an important treatable cause of RV dilatation and failure, has been the focus of many investigations in recent years. The goal of this article is to review the current state of knowledge regarding the pathophysiology of pulmonary regurgitation and its management. TOF VSD, sir, that means a single large non-restrictive defect with no obstruction to flow across the equalization of pressure on the both ventricles with subaortic and perimembranous and muscular region of ventricular septum with left to right shunt. It's due to the canal canal septal defect, the anterior left cephaloid deviation lead to the defect, which contain 4 pulmonary stenosis, hypertrophy of right ventricle with ventricular septal defect and overriding of aorta. RVOT anatomy, there will be anteriorly coronal septum will be anteriorly displaced, which is the commonest in the hypertrophy trabecular septomarginalis, hypertrophy of anterior wall of infundibular septum. In the presence of yes, sir.
Learn to practice to talk clearly and slowly. Okay. If your words are being swallowed or lost. Okay.
Yes,
so talk a little slowly and clearly. Practice this. Okay, it's important for your exam and future as well.
Okay, sir. In the presence of an unrestricted VSD, worsening RVOT increase the right ventricular pressure, drives right to left shunt across the VSD, reduces pulmonary blood flow and lead to hypoxemia. Assuming the PDA is closed and there is no collateral supply, then the more severe the RVOT, the more hypoxic the patient may be on presentation. The surgery for TOF is the one single stage intracardiac repair. One patient is fit for surgery, which include patch closure of VSD, separate the aorta back to the left ventricular with resection of the RVOT muscle bundle. With a transannular patch may be required to sufficiently enlarge the RVOT, but it lead to the obligatory pulmonary regurgitation. Sometimes associated lesion like ASD, PDA should be repaired with the intracardiac repair.
Slower and clearer.
Yes, okay. Post-TOF tetralogy of Fallot repair, there will be increased pulmonary regurgitation, which lead to the over the time pulmonary artery dilatation with increased pulmonary artery pulse pressure and volume. So, meanwhile, there will be due to the increased pulmonary regurgitation, RV right ventricular dilatation will be happening, which will increase the right ventricular compliance. This further contribute to the increase in pulmonary regurgitation over the time. In longer run, the post-tetralogy of Fallot repair, pulmonary regurgitation will lead to the chronic right ventricular volume load, which will further dilate the right ventricular, which will increase the right ventricular and systolic volume with decrease in right ventricular mass to volume ratio, which will increase again further contribute to the increase in right ventricular wall stress with the increase in right ventricular pressure. This increase in right ventricular wall stress will lead to the RV dysfunction, which further contributed to RVOT patch ischemia fibrosis with RV aneurysm occurrence in some patients. Which RV dysfunction, there will be sort of LV size and dysfunction, which will decrease the functional status, adverse clinical outcome in the patient.
You are not clear. I can't follow you.
Yes, sir. This post tetralogy of Fallot repair, the Longer follow-up of the patient revealed increase in pulmonary regurgitation due to the chronic right ventricular volume load due to the free PR, which lead to contribute for right ventricular dilatation. Due to there will be increased right ventricular and systolic volume and decrease in right ventricular mass to volume ratio, which will cause increase in right ventricular wall stress. So which lead to increase in RV pressure, and further it contribute to RV dysfunction. With RV dysfunction, the patient will have functional status, decrease in functional status, adverse clinical outcome, all the symptoms. And the symptoms are more seen at the early age repair. The symptoms are more in the patient on further follow-up. And sir, I spoke to pediatric cardiologists, so they told if we this ICR repair with free PR and RV to PA conduit. So with the patient who undergo with the pulmonary valvotomy or with the transcendental patch, they come with the RV dilatation, tricuspid regurgitation, RV failure, mostly around 20 years for the surgery. But in case of RV to PA conduit, these patients come with RV hypertrophy, RV failure at the mean age of 5 to 10 years for redo surgery for pulmonary valve implantation. So further, the structural and functional abnormality in post-operative tetralogy of Fallot. So structural abnormality, some are inherent to TOF repair, like partial or complete removal of pulmonary valve tissue, infundibulatory scar, VSD patch, and some are due to residual lesion, like not clearing the full right ventricular obstruction, ASD, VSD, and some acquired region like tricuspid valve abnormality. In functional abnormality, the right ventricular volume overload, which will be contributed by the pulmonary regurgitation, tricuspid regurgitation, left to right side. Secondly, pressure overload due to main or branch pulmonary artery stenosis or pulmonary vascular disease. With right ventricular systolic dysfunction and right ventricular diastolic function. Kane et al. In 2001 and 2003, he did a study in pulmonary valve implantation in swine. He noted that there is an increase in pulmonary regurgitation fraction from 33 to 37% mean at baseline to 49 to 55% at the 3 month. The factor that determine the degree of pulmonary regurgitation include the size of the regurgitant orifice, the diastolic pressure gradient between the main pulmonary artery and right ventricular, the capacitance of the pulmonary artery and duration of diastole. Effect this article, the lever as compared the right ventricle regurgitation is similar to the aortic regurgitation. And what he mentioned that the RV, the pulmonary regurgitation, there are no further data, so he just explained the mechanism of aortic regurgitation with the ventricular mechanics. So the understanding the aortic valve regurgitation pathophysiology help in understanding pulmonary valve and right ventricular mechanics in free EPR. Pathophysiological response to the LV and RV to severe chronic valve is almost similar. Many investigations divide the pathophysiological responses of the LV to severe chronic aortic regurgitation into 4 stages of variable duration, which include compensatory stage, failure of compensatory mechanism, further LV dilatation, and irreversible myocardial injury. Starting with compensatory state, the LV respond to the volume load of chronic AR with this series of compensatory changes, which include increase in end diastolic volume and increase in chamber compliance with the shift of the pressure volume curve to the right, thus accommodating the increased diastolic volume without a significant increase in end diastolic pressure. Combination of eccentric and concentric hypertrophy. Ventricular dilatation is characterized by cellular elongation, addition of myofibers, and a decrease in collagen content. These changes lead to an increase in diastolic volume and maintenance of relatively normal mass to volume ratio, which is compensated hypertrophy, and systolic fiber stress and global systolic function, and increase in stroke volume maintain forward flow within normal limits. At the sarcomere level, ventricular remodeling with the addition of myofiber in series maintain preload at normal or near normal levels. Afterload is increased as a result of increased valve stress and contractility remains normal. This stage may last for many years or even decades. The future course, the patient will have failure of compensatory mechanism, in which stage the characterized by continuous LV dilatation but with inadequate hypertrophy. So there will be decreased mass to volume ratio and increase in afterload, which is and systolic stress. As a result, the rate and magnitude of fiber shortening decreases. This stage manifests as decreased global systolic function, decrease in velocity of circumferential fiber shortening, shortening fraction, and ejection fraction, while entrenching myocardial contractility remain the same. Further, LV dilatation, worsening afterload mismatch, and progressive global systolic dysfunction and reduced myocardial contractility. Over the short term, the impaired contractility may be reversible, and elimination of the volume load by valve replacement or repair can result in complete functional recovery. Last is irreversible myocardial injury. Regurgitation continues intervention not done, but associated with fibrosis and increased interstitial collagen and fibronectin. Although wall replacement may still be tolerated in this stage and of clinical benefit, but myocardial mechanism do not return to the normal level. RV mechanics after top repair. So it's a linear correlation graph which depicted on a y-axis the RV and diastolic volume index with pulmonary regurgitation on x-axis. On observation, it is revealed that at RV-EDP index of 125 to 225, the pulmonary regurgitation is at around 40%. Clinical course and outcomes after the top repair. Knowledge of natural history and identification of risk factors for adverse clinical outcomes are important for determining the optimal timing of pulmonary valve replacement. The mortality rate nearly triples during the third postoperative decades. Numerous studies have shown that the late after top repair patients are at risk of exercise intolerance, heart failure, arrhythmias, and death. In addition, pulmonary, renal, hepatic, and other non-cardiac morbidities often complicate the clinical course of these patients. The common theme that has emerged from the literature on the risk of death in survival of TOF repair is that there are three major categories of outcome. History by patient, which includes syncope, older age at repair, electrophysiological marker, prolonged QRS duration, more than 180 seconds, sustained ventricular tachycardia, positive program ventricular stimulation study, hemodynamic sequelae of severe pulmonary regurgitation with enlargement of cardiac chamber ventricular dysfunction. In this study, method of investigation was the goal of the diagnostic evaluation patient with repaired top, identification of structural and functional abnormalities, evaluation of the severity of the hemodynamic abnormality, surveillance of the rate and degree of disease progression, and identification of marker of poor prognosis. History. An inactive lifestyle, deconditioning, obesity, and comorbidity like scoliosis, lung disease, development delay can manifest as decreased exercise intolerance, shortness of breath, and other symptoms, despite modest dilatation of the RV and normal functions. The biventricular dimension assessment and function exercise can be helpful in these circumstances. The following data obtained by history has been shown to predict adverse clinical outcomes, which include the age where the Tetralogy of Fallot repair was done, the time from repair to current evaluation, and history of syncope or symptoms of heart failure equivalent to NYHA class 1. These are the different investigation, which for method of investigation and follow-up. So first include history, as mentioned, as at repair, length of follow-up, and syncope symptom. Additionally, it will associated morbidity and level of activity. The advantage with history, integral part of clinical evaluation, might be difficult to, and disadvantage might be difficult to discern the cause of symptom. And usually history is taken after 1 year in the study. Physical examination, which will see for sign of heart failure, arrhythmia, sign of associated morbidities. In chest X-ray, we'll see for cardiomegaly, ECG for QRS duration, for any conduction abnormality, arrhythmia, Holter monitoring for 24 hours to check for the sustained VT, with any high-grade ectopic conduction abnormality. Again, exercise test included objective assessment of exercise capacity and resting lung function. The more important is echocardiogram, which include moderate or severe TR, biventricular dimension and function, pulmonary regurgitation, right ventricular outflow tract, and pulmonary artery of any obstruction is there, residual shunt, potential role for tissue Doppler imaging, The only disadvantage with 2D echocardiogram, it is limited by poor acoustic window in a patient who undergone a reduced surgery. Only quality assessment of right ventricle size and function and wall regurgitating condition. The newer and the most important in pulmonary regurgitation diagnosis is cardiac MR, which is give us body surface area adjusted right ventricular and diastolic and end systolic volume, RV and LV ejection fraction, quantitative additional potential data which give quantitative assessment of wall regurgitation, right ventricular and outflow tract, any aneurysm, myocardial fibrosis, pulmonary artery anatomy and associated anomalies. It has a prognostic value. The disadvantage is the normal MRI contraindications is any metal implant or claustrophobia. And it is advised to do every 2 years, every second yearly, the MR, cardiac MR should be done for evaluation. CT, the data predict outcome are same as a MRI. The additional info which was given by CT is pulmonary artery anatomy and associated anomalies. There are certain role of nuclear imaging also, which include ventriculography, which will give us an idea regarding biventricular function. The disadvantage with this is limited accuracy for assessment of the RV ionizing radiation exposure. Electrophysiologic testing is include positive program ventricular simulation, which will help in arrhythmia mapping and characterization. And the last is a cardiac catheterization, which will give us the important data but regarding hemodynamic data and coronary artery assessment. The echocardiogram, as I said earlier, measurement of the left and right ventricle are important. The color Doppler detects residual signs or allows semi-quantitative grading of wall regurgitation. Spectral Doppler is used to measure flow velocities and to predict pressure difference across obstructive lesion. The RV outflow tract obstruction assessment of RV systolic function based on the peak velocity of the tricuspid regurgitation. The newer thing, tissue Doppler imaging, a non-geometric method of measuring myocardial velocities, may be useful method for quantitative assessment of biventricular function after TOF repair. This cardiac MR, as mentioned earlier, right now it is the most preferred method for non-invasive imaging in patient with post follow-up or repaired TOF. It will give quantitative assessment of wall regurgitation, RVOT, aneurysm, myocardial fibrosis, pulmonary artery anatomy, and associated anomalies. The CT, the use of ECG gated CT has allowed reconstruction of temporally resolved images of the ventricular and calculation of volume and ejection fraction. The major drawbacks with CT is exposure to the ionizing radiation. A multi-detector CT angiography general and ECG gated multi-detector CT in particular are associated with exposure to much higher radiation than the standard CT. Given the risk of cancer, invasive related it is, and that patient with repaired TOF require longitudinal follow-up. The drawbacks of radiation exposure and its associated risk of cancer are important limitation of CT in this patient. Additional limitations include relatively low temporal resolution, inability to measure blood flow, and relatively high rate of side effect with contrast agent. A nuclear imaging, as mentioned earlier, nuclear ventriculography has been seen in a patient with repaired TOF for assessment of RV size and function. Electrophysiological study to the map the severe increased risk of sudden death after TOF repair, including the increased QRS complex duration on ECG, abnormality on signal, average ECG, T-wave ultrans measured by exercise test and heart rate turbulence evaluated at 24-hour Holter monitoring. Microvolt level T-wave ultrans, heart rate variability, and baroreflex sensitivity are predictor of sustained ventricular tachycardia and cardiac death post-myocardial infarction. Exercise testing. The result of an exercise test must be interpreted with caution because reduced exercise capacity can be caused by many factors, including insufficient or lack of training or motivation, lung diseases, musculoskeletal anomalies, and development delay. It provides objective assessment of exercise capacity, can detect exercise-induced arrhythmias, and can be used longitudinally to detect changes in overall cardiorespiratory status over time. Cardiac catheterization will give us about the hemodynamic data with the coronary flow. Indication and timing of pulmonary valve replacement. Based on risk-benefit analysis that takes into account of natural history and pathophysiology of the disease, risk factor for adverse outcome if no intervention are performed, risk of the procedure and its potential result. The natural history include heart failure, arrhythmia, and the death are late complication in gestation. Predictor of adverse clinical outcome include moderate to severe RV dilatation, RV dysfunction, LV dysfunction, QRS duration of more than 180 millisecond, SENCO positive program ventricular stimulation, steady and sustained ventricular tachycardia. The surgical risk of pulmonary valve replacement, the operating mortality of around the further multiple studies showed around 2%, which included that time the publication of this article. There was some social like Sunny Sugarcane, which is 85 with the number of patient, 11 patient, the mortality was 0. With Children's Memorial Hospital in Chicago, where 70% the mortality was 1. Like that, the study, and they found out that it was around 1 to 2% of the mortality. There is, however, continued low risk of death after pulmonary valve replacement. Terip et al. In 2005, this paper, Optimal Timing of Pulmonary Valve Replacement in Adult After TOF Repair, reported that 92% survival at 5 years of age and 86% survival at the 10 year in 70 adult patients after pulmonary valve replacement. Deceasel et al. In 2001, in his paper Late Pulmonary Valve Replacement After TOF, reported 95% survival at 5 years of age and 76% survival at the 10 years in a 42 patient study. When considering the risk associated with pulmonary valve replacement, the risk of valve failure should also be considered. All valve inserted in the pulmonary position have a limited life expectancy with the wide variation in rates of freedom from valve failure and reabortion, depending on the type of valve and patient is. Cauldron et al. In 2000 reported freedom from reoperation in 81% of patients after 5 years, 58 at 10 year, and 41% at the 15 year. These authors, as well as many others, have shown that young age at pulmonary valve replacement is associated with a higher rate of valve failure and early reoperation. The benefits of pulmonary valve replacement included the elimination or significant reduction of pulmonary regurgitation is associated with symptomatic improvement, decrease in RV and diastolic and end systolic volume, and no significant changes in RV ejection fraction. In addition, there is some evidence that indices of exercise tolerance also improves. Therin et al. In 2005 reported that the incidence of ventricular tachycardia was lower after pulmonary valve replacement, 9% post-operatively compared to the 23 which was pre-operatively, and that the rate of increase in QRS duration has stabilized after the procedure. Although the above mentioned benefits are important, they were primarily documented in relatively small study which short follow-up period. Importantly, there is no clear evidence that pulmonary valve replacement improves survival. On other hand, several reports have shown that improvement in RV mechanism is disadvantage in patients who undergo the procedure when their RV size and function are markedly abnormal. Harrison et al. In 2005 reported that RV size did not return to normal in any of the 7 patients whose preoperative and diastolic volume index was greater than 170 milliliter per meter square, whereas they observed normalization of RV size in 9 of the 10 patients where preoperative and diastolic volume index was around 170 ml per meter square or lower than that. The same other in previous publication showed that no improvement in RV size and function after pulmonary valve replacement in adult with severe RV dilatation, where mean RV and diastolic volume index was around 227 millimeter per meter square, and moderate dysfunction. Mean RV ejection fraction are around 36%. In contrast, one Satran et al. Replaced the pulmonary valve in patients with less severe RV dilatation, mean RV and diastolic volume index of 167 millimeter per meter square. These authors reported substantial decrease in RV size, where mean post-operative RV volume index was around 113 millimeter per meter square, a benefit that was sustained at the average of 9 months after surgery during follow-up. The criteria for pulmonary valve replacement. The timing and the indication of pulmonary valve replacement after TOF repair must balance between the benefit of elimination of right ventricular volume load before irreversible dysfunction occurs and the disadvantage of valve failure and need for re-intervention, which are more frequent with earlier operation. With the above consideration in mind, the following are recommendations for pulmonary valve replacement that are currently using clinical trial of surgical approaches in the patient population. A repair TOF or similar physiology with moderate or severe pulmonary regurgitation with included regurgitating fraction around 25 is by cardiac MR or two or more of the following criteria, which include right ventricular end diastolic volume index of around 160 millimeter per meter square, Z score of 5, RV end systolic volume index of 70 ml per meter square, LV end diastolic volume index of 65 ml per meter square, RV ejection fraction of 45% RVOT aneurysm, clinical criteria which included exercise intolerance, symptom and sign of heart failure, cardiac medication, syncope, sustained ventricular tachycardia, other hemodynamically significant lesions such as moderate or severe tricuspid regurgitation, residual arterial and ventricular septal defects, and severe aortic regurgitation may trigger referral for surgery in patients with moderate or severe pulmonary regurgitation. In the absence of criteria, as above mentioned, 1 to 6, pulmonary valve replacement should be considered on a case-by-case basis. Due to higher risk of adverse clinical outcomes in patients who underwent TOF repair at the age of 3, pulmonary valve replacement may be indicated sooner and in presence of less severe right ventricular dilatation and dysfunction. The available data till the study did not support pulmonary valve replacement in young patients with mild to moderate RV dilatation, but RV Z score of around 3, normal systolic function with RVEF of around 50%, no additional risk factor. These criteria will continue to evolve as more information become available, specifically better understanding of the pathophysiological responses of the RV to pulmonary regurgitation, induced volume load, which will help to refine the determination of when RV mechanics transition from reversible to irreversible dysfunction. Another area that will influence the timing and indication for pulmonary valve replacement is improvement in the longevity of the implantable valves. The theoretical benefit of bioengineered semilunar valves is of particular interest for this patient population. Finally, further development of transcatheter techniques for implantation and reimplantation of pulmonary valve in patients who with repaired TOF and large RV outflow tracts may also lower the threshold for pulmonary valve replacement. Thank you.
So, how many patients were studied in this article?
Yes, sir. 206, sir.
So, what did you understand in this article? The reason I gave you this article for review is in the olden days, tetralogy, the main thing was earlier palliative procedures to stabilize the patient and then total ICR at the appropriate age. And the good outcome of a tetralogy repair used to be there is no residual VSD or no RVOT gradient. That was the criteria that was used, and then subsequently the patients were followed up. The recent concept of gross PR and RV dysfunction has come about now, which is causing problems in the late survivors, and that is the reason why pulmonary valve in this thing was instructed. I mean, pulmonary valve assessment and, if necessary, replacement or repair has been introduced.
Okay.
So, in this context, I wish you had, as the sir will always tell you, what is our experience, what is NH experience, how many cases in the last 5 years at least underwent reoperation for pulmonary valve or RV dysfunction. Do you know? Did you
No, sir. No, I spoke to Abhijit sir and Divya sir. Abhijit Joshi sir, I spoke to sir, fellow and Divya sir.
Abhijit Joshi has just joined this fellowship program 1 year ago, not even 1 year ago. and Divya may not know the entire scenario. You should talk to somebody senior in the as consultant. You didn't involve any of the consultants. They don't
No,
want
sir.
to come.
No, sir. Raghu
They-
sir is there. Sir. I spoke to Raghu sir.
Okay. So, but what happens is we should know what is being done in our own institution. And actually, this could be one of the topics for a thesis topic for one of the newer batches. They could go back and see how many cases of tetralogy have been done in the last 5 years, how many or long term, at least 5 years is too short. Long term, this thing overall, how many tetralogies have been done, and then how many of them have at least come back for reoperation, or at least study the reoperation and the time interval from the primary repair to the time of reoperation, and then what was the outcome, what were the criteria, why was they required reoperation, and things like that. That could be a good thesis topic as well. You have to discuss this with your consultants and then work on that. So the crux of the matter is that RV dysfunction does occur usually about 10 years after the primary repair, and that causes problems in the later life of the patient, and they need to be addressed.
Yes, sir.
When and how and why is what you should know.
Okay, sir.
Okay. The
Yes, sir.
timing of the reintervention and how. What are the things? What are the various techniques that you can employ before you which you can tackle the PR and then the RV dysfunction. This was in continuation with the previous article that we said was what is the outcome or what are the things with the valve preservation in the primary repair. Different techniques of valve preservation, and then does that make a difference? And that is how you should learn whether you could prevent these RV dysfunction in the future, or if it has occurred, what will you do now? That is what you have to know.
Okay,
Of
sir.
course, this is probably a little more technical aspect for pediatric cardiac surgery. May not be very relevant for you for your general DNB cardiac surgery exam, but still it is good to know. If you know, then you will get more extra marks and extra brownie points in your
Okay,
exam.
Okay, sir.
Anything to say, sir?
Sir.
Can't hear you, sir.
Yes.
Sir, you have to unmute.
When you started your discussion, you mentioned about the BSD, but most important, you have discussed the type of right ventricular outflow tract obstruction in tetralogy. Most often, it's infundibular. Very often, about 75% infundibular plus valvular. Some of them may be supravalvular. Some of them may be hyperplasia of the whole main pulmonary artery or branch stenosis. The most commonly we find infundibular stenosis plus a bicuspid pulmonary valve. Previously, or some of them very rarely, maybe there is no valve as a ring-like valve. So it all depends on how you deal with that to reduce the amount of pulmonary regurgitation. I remember in olden days, you used to excite the whole pulmonary valve. That's not the correct thing to do. Now, very often I said it's a bicuspid pulmonary valve. So actually, when you do a transannular, you have to go to the commission, not disturbing the main pulmonary valve. So that reduces the pulmonary regurgitation to a certain extent. Then came the concept of a monocusp valve on the outflow patch. That also mainly they used to do for a absent pulmonary valve syndrome. It was not very successful. And nowadays, what you do pathology in a younger and younger babies nowadays. You put only a very small chance that you can decide preoperatively whether this is good,
Yes, sir.
whether the patient needs a transfusion. And if you do only limited patch, because the reduction. So that is one thing. Then the concept usually after 15 to 20 years, where you put a large transfusion patch and where the three pulmonary regurgitation, the RV goes on dilating and it fades. So the concept actually in the initial years of indication for PVR was about, what you said, CMRI, where the diastolic volume, the right ventricle was 160. And now I think some of the articles say they reduced it to 150 ml per meter square.
Yes,
and
sir.
the end systolic about RV of 70 and ejection fraction of RV of equal to or less than 45% and ejection fraction of the LV of 55% or less. So these are the classical indications. And when the right ventricle goes on dilating, can produce arrhythmia. So tachyarrhythmia is one of the causes. That's why one of the earliest indications that you give that this may have a bad prognosis is one when the QRS time gets prolonged. As you said, if it is more than 180 milliseconds, there's a chance of sudden death in such cases.
Sir.
Nowadays, you try to do valve replacement, not waiting for 160 or at 150 itself you do.
Yes, sir.
Otherwise, the severe regurgitation produces a remodeling of the left ventricle. And in such cases, even if you put a pulmonary valve, the reverse remodeling doesn't. The other thing you didn't mention at all is that nowadays the concept of a transcatheter
Yes.
pulmonary valve replacement. The only problem is that the because of the severe pulmonary regurgitation, the artery is dilated, the annulus, because there's a transcatheter patch dilated, and the main pulmonary artery is dilated. So such a large valve is not available. Actually, basics of a transcatheter valve is mainly for stenotic valve. When you dilate and then put the valve, it stays there. But in these cases, where you need a valve replacement, sometimes they do hybrid procedure. Means partly surgical, partly catheter based. Partly surgical means you go around the pulmonary artery and do something like a pulmonary artery banding. And on that, you shake the valve. That's what I have read. So the other thing, as I always said, how many cases of surgical PVR has been done in this case in our hospital after tetralogy, and how many catheter-based valve replacement has been done? You could have looked into statistics and said that. We have said it many times. Very important. How many you think has been done?
He doesn't know. He didn't look for it.
No, sir. I'll check on this, sir.
Yes, that's very important. And how many cat-based PVR has been done? Okay.
Yes, sir.
Dr. Raghu is here. Thank you, Dr. Raghu, for joining us. Can you give us some input?
So, NH experience. Thank you.
Hello, sir. Hello.
Morning.
Yeah.
Yes,
Good
morning,
morning,
sir.
Sir, one of the thing is, in the initial surgery, if you use a trans or a trans PA, we can preserve the valve.
Yeah.
That's one thing which, and regarding the hybrid procedure, along with the banding, now the concept is we put a stent, bare metal stent, and we do a small thoracotomy and fix it, then they can put a valve. Yeah, fixing either through a suture or like a screw. Hello.
What
Yeah.
about surgical PVR? How many you've done, you think, in this?
Sir, no idea, sir.
Do you have any statistics about what is being done in our institution? That is what I would.
No, sir. No, now actually, recently, in the sense because since both mechanical and bioprosthetic are not good, the new concept is they are putting a conduit actually instead of this thing. So we don't know the exact data how many this thing. We should find out, sir, because now since there was one study at AIMS, sir, actually Dr. Devguru was conducting regarding mechanical and bioprosthetic at pulmonary valve position. So I don't know whether they have published it. I'll find out. So, but we don't know what is the ideal procedure also. Whether it's where to put a conduit or put one of the valve in place.
Exactly. That is the
I
reason
thought
why.
mechanical was disasters on the right side. That's my whole teaching, is that tricuspid or pulmonary valve replaced by a mechanical. Invariably, I have seen most of them thrombosing.
Yes, sir. Yes, sir.
That thing, bioprosthetic, they say the advantage is sometimes you can put a valve in a valve.
Yes, sir. Yes, sir.
Right, stenosis, but that the heart may tolerate. I don't know.
Yeah, yeah. There's no acute emergency in that. At least they'll give time for us.
Yeah, the one thing is, if we know how many have been done, what has been done, we can learn from our own this thing, whether we are doing the right thing or the wrong thing. So that is very important for us to progress. So a self-audit is something that I'm trying to instill into these boys and girls, so that you know, you will realize whether you are doing the right thing or is there any chance for improvement, how better to do this, and these are the things that they should start thinking about. You know, it's very important for you to progress. That is the only way to progress.
I thought well, Narayan probably does the maximum number of pathologies in the world. So I think they're good study to follow up with this. How many of them require pulmonary valve replacement?
So after 3 months, we don't have a follow-up.
What are the indications and timing? I read it used to be 160 ml of the in CMRI, the RV volume ml per meter square. From that reduced to 150 ml or something. I'm not sure what exactly.
Yes, sir, you're right, sir. In the same author in 2013, sir, he published a meta-analysis in that they've changed the indication. So RVEDV less than 150 ml per meter square, right ventricular and systolic less than 82 ml per meter square, with RVE of 45%, sir.
Yeah. Good. Any other comments? Thanks, sir.
And sir, bioprosthetic valve, there are two valves which have been used. One is Melody, sir, the first valve from Edward Life Sciences, which was used from 2003, and newer one is Sapiens valve, sir, which is now the Sapiens 3 is there FDA approved, which is used, which come with the RVOT patch. So they plan, sir. This is what I've been told, and they do as a cardiac MRI grading or for glanding zone. What the pediatric cardiologist told me. I spoke with him, sir.
The Melody valve is one of the earliest, I thought for aortic valve replacement, Medtronic has replaced that with the code, the Evolute valve, and the Sapiens valve. These are the valves usually used for aortic valve replacement. But today, Melody valve is one of the earliest of the Medtronic,
Yes, sir.
Yeah.
Yes.
Yes.
It would be worthwhile looking at this. How many of our patients, overall, how many tetralogies we have done, how many of them have come back for a redo, and then what was the indication and what age and how many years post-op. It would be some interesting to have an idea of what we are doing in our own institution. one of the boys who is now posted in pediatric surgery should be able to find some time and look up statistics.
Okay, sir.
I don't know who are all there in the pediatric surgery now. Who are posted there?
Sir, Shreyash is with Sekhar Rao, sir.
Hmm.
Dr. Jitendra is with Siddha sir and calling, sir.
Hmm.
And Dr. Chabi is with Suresh sir.
Hmm. Yeah, somebody should have
Yes,
the
sir.
interest and look into this. You know,
Sure,
it's really worthwhile to know.
Yes, sir.
Okay. Any other comments by anybody? All right. Thank you, Dr. Raghu, for joining us. We
Thank
would like to see you more often.
Thank you. Thank you very much.
Thank you, sir.
Thank you,
sir.
sir.
Thank you, sir.
Okay. Thanks, everybody.
Thank you, sir.